we ended our wonderful session. Now we will proceed to our next session, which is on anastomotic leaks. And our respected moderators are Parthasarathy G. Thank you.
I thank the organizers for giving us this opportunity to conduct this panel discussion. Let me first invite the panelists for this session. We have Dr. Ajay Sharma. We have Dr. Nisar Hamdani. Dr. Tuhin Mandal. Dr. Suddhasattwa and Dr. Utpal Anand. So today we've been given this job of discussing anastomotic leaks. So out of the 4 or 5 options given, we have decided to discuss 2 of the most common, one very common and one very important anastomotic leaks. One is the duodenal leaks and second one is Chyle leak. So duodenal leaks are very common in our practice. Chyle leaks are uncommon, but when they happen, we need to know what to do. So the format of this is we'll go by a case capsule method where I'll give you an imaginary scenario and keep giving you clinical scenarios and let us ask the panelists about the opinion. So shall we start? Yes. So the first is you have before coming for the IASG, you have just finished radical distal subtotal gastrectomy for carcinoma stomach and you have come here and it's post-op day 5. Surgery was fairly uneventful and that's why you are peacefully enjoying the conference here. Your associate calls you and says, sir, today this is the drain. There was a drain kept in the right subaortic region and he sends a WhatsApp picture of this and your heart stops. Dr. Ajay, what would you do now?
Obviously, it's a bile. I think it's obvious bile leak which is coming from your. You told it's a subhepatic drain, na?
Yes.
So subhepatic drain bile means obviously a duodenal injury, duodenal blowout, possibly the sutures or staplers, whatever you have taken, that has given way, and there is some leak from that side.
Okay. Will any of you think of any other possibility for having this sort of a drainage?
Very unlikely, because other possibility, it can be though it can be rare that while during a dissection you have injured a bile duct or you have done a gallbladder while during cautery it has gone.
Yes.
So that can be possible, but more likely I would think of because where you have a suture line, that is a more likely cause.
Yes, I accept.
Yeah, so since this is day 5, if there was an injury on table, then probably the other sources would have come before. So most likely duodenal, but then ischemic injuries is something which also needs to be kept in mind.
Ischemic injury of?
For the bile duct or the other areas.
Yes.
So that needs to be there.
So the most common possibility is the duodenal stump is leaking, but you also need to consider other possibilities because this is a malignancy case. You do not know. I have not told you how difficult the operation was. You thought it was uneventful, but maybe there was an event. There's one more possibility.
One point I would add here, that we should, though the duodenal this blowout is very likely, but we should not rule out in clinical practice the possibilities of leakage from feeding jejunostomy site in case we are done, or even the gastrojejunostomy site.
Yes.
They should be kept in mind.
GJ leak is something which we have to consider. FJ leaks may not present like this. The patient might present with peritonitis, but GJ leak is definitely a possibility. It is very rare, but it still can happen. So just finding bile in the drain. The most common thing is, of course, the duodenal leak, but also do consider the other options. And then you want to ask your associate how the patient is, and this is how the patient is. He sends you a picture of the monitor. Everything seems hunky-dory, no tachycardia. Patient is good. And what now? Ajay sir, what will you advise your associate to do now?
As long as the patient is stable, I think I'll be worried because it is definitely a bile in the drain at this point in time. It is worrying, but stability of the patient makes me more stable that I can evaluate him. Now, the most important abnormalities that can happen with this content in the drain is, one is a collection which is somewhere, but it is still not showing on my vital parameters. Second thing is the patient is having an imbalance in the electrolytes because it will have a loss of electrolyte loss. So that is second thing.
It's
that
only
is going to
400
worry
ml.
me.
It's not a very large amount. The drain is only 400 ml.
So that is more worrying. Where is less 5 liters going? So maybe, no, taking jokes apart, but I would be worried that if it is 400 ml, it's slightly good.
It's a
If
stump
as
leak.
long
It
as
still has
patient-
a way to.
As long as patient is stable, I know it is a controlled fistula, that's what you want to say, but maybe sometimes vitals, presently the vitals are fine, maybe after some time it may show up.
So what
but
will you tell him to do?
I'll ask him just to wait for some time as long as he's stable, not to run, but get a CBC, get a electrolytes done, and if required, a sonography done at this point in time, not
Okay.
directly jumping on to CT
So,
scan at this
meaning
point.
you will not have a knee-jerk reaction. You will just want to hold your horses and maybe do a basic workup. But ultrasound, no harm in doing that. Yes. So this is answered. So you'll wait and watch. Day 7 again, he calls and he sends a picture, and this is the patient. Heart rate is 133 and saturation is okay, blood pressure is okay. Dr. Sen, now what would you want to tell him?
So basically, I'll need to know whether, because there is only tachycardia, the respiratory rate has also gone up, so there is definitely an underlying sepsis. First and foremost, I would like to do a CT scan to find out whether there is a possibility of having a controlled fistula or this is going in towards a peritonitis. And what are the clinical symptoms? I mean, in the sense, what is the abdomen? Is it already into a frank-blown peritonitis? Or is it just a collection probably in the upper abdomen is guarding? The rest of the abdomen is soft. So a lot of things would depend on that. But I would depend on the CT scan. And
Would you do a CECT or a plain CT scan?
see, basically both can be done. For a collection, a non-contrast CT is also fine. But depending on
What
the
extra do you want to find out by giving an IV contrast in this patient, in this sitting?
As such, other than ischemia, nothing would be picked up. If there is any vascular damage or etc., there is no bleeding associated, so there is no point in doing. So we don't
Ischemia
need
meaning
a
what
CCT.
ischemia you are worried about now?
So we don't need a CCT exactly.
Yes,
We
so
would
you
need
just
a
need a plain
non-contrast
CT.
CT scan. Yeah. So just to rule out a collection, which can be drained or not, and whether there is a possibility of becoming an uncontrolled fistula. That's what we need.
He calls and asks you, sir, should I give him oral contrast?
Oral contrast.
Is there any use of giving oral contrast
There
here?
is no benefit unless you are suspecting a gastrojejunostomy leak.
So
But
by
it's
now,
very-
how are you able to differentiate that it is definitely not a GJ leak and it's a duodenal stump leak?
See, the first is may have done an ultrasonography. Okay. The second thing is the content color. So that would go in favor of more like a duodenal leak. And the possibility of a GJ leak is very rare. And then abdominal science would tell us, because the CT would tell what is the type of the collection, where is the location of the collection. So that would give us an idea also.
Anybody wants to add anything to this?
My opinion is if we are going for a CCT, then it should be contrast enhanced CCT with full oral, with giving oral contrast in order to get a complete picture of that. Otherwise, do ultrasound. If there is errant collections, then drain out. If you are going for CT scan, then do complete CT scan with contrast enhanced CT scan and oral contrast. If renal parameters permits us to do.
The entire panel agrees that we need to go for an IV contrast. Remember, patient is having tachycardia. He is most likely going into sepsis. He will be dehydrated. His urine is likely to fall. He might have a septic shock. And unless it's absolutely necessary, you still want to go ahead with an IV contrast in this patient?
Depending upon, I've already told if creatinine is okay, if urine output is good, then CCT abdomen with full protocol.
Dr. Nisar, Dr. Tuhin, both of you agree to this?
I also agree, Dr. Anand. I will go for a full, if creatinine allows, renal function allows, then we will definitely go for CCT with oral and IV contrast. That will give a full picture. There will be no confusion about the source where from it is coming, as well as we can visualize the other organs also.
Okay. CT with oral contrast shows there is no GJ leak. There is a collection in the right subphrenic region. There is no collection in the pelvis. There is no active oral contrast or IV contrast excitation anywhere. So now what would you do, Dr. Tuhin? The resident calls you with all these findings, and these are the patient parameters. What will you tell him now?
So
What to do?
The CT is showing.
CT shows a right subphrenic collection. There's no other collection anywhere in the abdomen.
Okay.
There is no oral contrast leakage from anywhere. Neither is there an IV contrast leak.
Okay. So definitely the clinical scenario is suggesting that patient is having some sepsis going on. So I'll see the total count and basic infection parameters. And the collection needs to be drained, that is for sure.
So how do you want to drain the collection? You want them to take the patient to the theatre?
No, definitely I will go for.
You want them to manipulate the drain a bit?
IR guy to put a percutaneous pictal catheter.
So you don't want to take him to the theatre immediately?
Definitely no.
The panel agrees to this point?
I think normally the drain position will give us a clue whether the drain is in right position or not. We usually ask our intervention radiologist, see that and reposition the drain as per our required. If it is not in the cavity, just place it in the cavity. The same drain may work. We have to know two things. One thing is, as a surgeon, we put a larger size drain. And the intervention radiologist will put a smaller size drain. So our drain will work much better than what they will put. And if there is a loculated collection other than this, then definitely that may require.
So in this case, there is a subphrenic collection. So manipulation may not solve the issue. Dr. Sen?
So basically, see, normally somebody would have put in either a 28 or a 32 ADK. We put in a 32. So that drain, the chances of success of not getting blocked is much better. So remanipulation and repositioning of the drain is the first option. In case still it doesn't drain, then we would have to have additional pigtail drains with the widest possible bore. Now what I tell my radiologist is, if you need my help, I'll be there, but try to put in at least a 20 to 24 French. I mean, don't go for your just pigtail, that doesn't help. So put in as wide as possible, a surgical drain if it's possible.
Where do you want to put it? Into the collection or near the duodenal stump?
Depending on where is the first drain. If it is draining well, then the collection that is not getting drained. So there I would put it.
Okay.
My opinion is, if you have done CT abdomen and it is showing that drain is in good position and it is not a fistula is related to drain and still there is undrained collection somewhere, then I will try to ultrasound guided percutaneous drain rather than to manipulate same drain and do more harm to the patient.
Yeah. So I think the panel is more or less uniform on this. If your surgical drain has not been draining, then there is a point in manipulating it. But any collection which is further away from the duodenal region has to be drained with an independent radiological guided drain. So that is the story so far. And so the management, we have decided we will go ahead with a radiological drainage. Post-op day 8, another bad day starts. He calls again, sir, today's drain color is this. What to do?
You are having a bad
Dr. Utpal,
patient.
sir.
You are having a bad patient.
There are many possibilities.
You are having a bad time rather.
Change your practices. I think so.
You wake up to a WhatsApp picture like this at 6 a.m.
There are many possibilities of this blood in drain.
Can this happen? First of all, can this happen in this patient? In this scenario, can you have a drain like this, which was very nice bile till yesterday, and today morning the resident sends a picture? Why do you think this happened?
It can, but my possibility is this drain output is good. It's around 300 to 400 ml. The first possibility is to rule out any pseudoaneurysm, especially from the right gastroepiploic artery or gastroduodenal or left gastric artery or splenic artery. But more common in this type of scenario we see in clinical practice is, in the background of sepsis, there are many raw area in the retroperitoneal area. So there is no definite source of bleed, but there is ooze, venous ooze from that area. So we need to rule out that portion also. And third possibility is intranumeral from the suture line. This is not uncommon. So if first option is we go for CCT with contrast and CT angio to rule out pseudoaneurysm. If it is all right, there is no.
There's a lot of blood in the drain. So the resident is calling and asking what to do now.
My first is CT. I will order for CT angio to rule out any pseudoaneurysm because significant blood in the drain.
Anybody wants to take this patient to theatre right away?
In the meantime, I will also
clamp the drain.
In the meantime, I will also say the vitals.
Jokes apart, please don't take it seriously.
Does any of the panelists think that this patient has to go to the theatre right away? Dr. Tuhin?
So clamping won't solve the problem probably.
No,
But
that was just a joke, please. Please don't take
I
that.
don't want to hide it, but we'll definitely allow it to come out. And this is if this is the drain, I will definitely ask the patient, my resident, what is the clinical condition of this patient.
Obviously, with a drain like this, your patient is not going to be okay.
Is he
He's going to be
is he in
tachycardic,
shock? Is he
BP
in,
borderline.
Is he
urine is
shocked?
borderline.
Yes, sir. So definitely my first priority will be to resuscitate the patient hemodynamically as well
That
as
they have started in the ICU. Your resident is asking two questions. Sir, should I shift him for a CT? Should I take him to the theatre? What would you do? I want each of the panelists to give only the answer. Dr. Tuhin,
Sir, my opinion
OT or
is
CT?
CT.
Dr. Sen?
If patient is
No, just answer. Dr. Sen?
8 post-op day, I would prefer a CT angiography after
CT
stabilization.
angio. Sir?
CT angio, definitely CT angio.
No, I won't give a simple answer. It basically depends on the tachycardia and the rate of filling of the drain. If the rate is fast, I'll take the patient to see OT. If it is a gradual increase, I'll prefer to do a CT.
No. See, you are now 1,000 kilometers away from the patient. Okay. The resident calls and says heart rate is 140, urine output is 30 ml per hour, BP is, everything is borderline, 110 by 60.
Right.
This is the usual scenario you get.
Right.
If it's a frankly hypotensive patient, it doesn't have much dilemma. The patient, your resident might have already posted the patient for surgery.
For
This is a
CT,
borderline patient who might go in either ways.
Then CT will be preferable. Because,
CT.
Yes.
Ajay sir?
Yeah, I think CT is preferable, but I think you are giving us a very bland picture. What they usually there's an old dictum: nothing happens immediately. If you are having this patient for last 6 hours who is having a gradual increasing blood, so that then the alarm is much more earlier. Now the scenario what you are telling is suddenly had a gush of blood of 800 ml. This is usually a sentinel bleed which is significant.
So today is
so
Sunday
you
morning.
should get a CT. You should get
So
a CT.
he must have
scan
had a
immediately.
sentinel bleed on Saturday night, and obviously Saturday night is a bad time for a post-op patient.
Yeah.
And Sunday morning is the time when your intensivist has seen and your resident has walked in for rounds. So most probably the sentinel part has happened and the
First thing
final.
CT scan. First thing is CT scan. Definitely you should keep your OT alarm, but CT scan is the first thing.
What if you don't have an interventional radiologist? Would you still want to do a CT?
I think
On a Sunday. This is a Sunday. Your patient is
Obvious-
bleeding.
it is something like if you don't know the road map, you would like to run. No, I'll need a road map. I like my radiologist to immediately get a CT scan done, and maybe I'll shift him directly from the CT scan to the OT. If I find if my radiologist is not available, I know that there is a pseudoaneurysm which is bleeding. I have to do it surgically, but I should know what I have to do surgically. If suppose I have a stump which is now having a spurter at the margin, I know I have to just put a suture over there. That makes the things easier. But I should know what I am going to do.
Okay, so
I
all the
fully-
panelists have agreed that this patient should first get a CT. What sort of CT do you want? You want a CT angio or a CECT?
CT angiography.
CT angiography. Okay, so that we are all agreed upon.
But
Does
I
anybody
think-
in the
I
audience feel that this patient has to go to the theatre right away?
Sepsis can be there, but
I don't think antibiotics is going to stop the bleed now. Whatever is the cause, whether it is the duodenal juice which has digested the blood vessel or a infection, the final thing which has happened is the blood vessel has blown out. So now we need to take a quick decision, and the audience also agrees that this patient has to go for a CT angio.
So
Okay,
the
but
message
you
is very
you pointed
clear.
out that
When the
if there
patient
is-
had a problem earlier, he required a triple phase or a contrast enhanced CT scan. Now he needs a CT angio. So the message is clear.
Yes.
2 CT scans and 2 different scenarios.
see, and the other thing is why we need a CT angiogram, not a straight surgery, is because without the roadmap on a day POD 8, there's going to be a lot of inflammation. You don't even know whether you have to expect the bleeding and what to expect inside.
Okay.
So that is important. And you said about intervention
No, I think
radiologist.
we have reached a consensus on that. Everybody agrees that he needs a CT. Okay, quickly, Dr. Tuhin, why do you think this patient developed a blowout? Now you start introspecting, you start wondering, why did this patient have this problem? What are the most possible reasons you start thinking about? Quickly, tell me a few pointers.
Sir, if we start if it is a preoperative, we start from the preoperative conditions also. If patient is not that, the primary disease usually causes malnutrition, is a malnourished patient.
Okay, malnutrition. Second
Number
reason?
2. Second is if associated comorbid illness like diabetes, like pneumonia and COPD.
No, I want direct causes. One is malnutrition, agreed. Any other cause you want?
Intraoperatively, if there is inadequate closure, inadequate
Meaning-
technical failure.
Technical failure.
Technical failure.
Very good.
Number
Yes,
2.
then agreed.
Number 3 is if there was a difficult stump. The stump is so small and is near to the capsule of the pancreas, so it is a difficult stump. And
This was a case of carcinoma stomach. Would you expect a difficult stump in a patient with malignancy? In what scenario would you find the stump to be a difficult one? Of course, that's very common in ulcer settings where you have a scarred duodenum and you're not able to close it. In a CS stomach, is there a scenario where you would find a difficult stomach? Can somebody from the
We
panel?
say, sir, it's a difficult gastrectomy because sometimes the tumor go up to the margin of the pylorus and reaching near the D1. So
Okay.
in that case, that stump may be too small to be closed comparatively. So that we may call it a difficult gastrectomy. And the stump closure is very critical in this scenario. If some reinforcement or drainage has not been done intraoperatively, that may blow out.
Okay. Any other risk factor you think you introspect and find maybe this, I should have thought about this?
I think two things are very important. One is an ischemic stump. What was the dissection or the mobilization?
Yes.
And second thing is whether we are at all looking at an R1 disease, because it's ultimately a malignancy. And
That's a very important point. You could have done an R1 dissection and that stump is never going to heal. That's a stump which is going to leak. Ajay, sir.
I think almost all, I think that was the session going on yesterday and day before, that if it is a surgical error, surgical problem, 0, 1, 2 are the main critical areas, days. If it is beyond day 3, it is usually some other cause which is leading to it. So definitely ischemia comes into day 3, day 4, infection leading to erosion, abscess leading to erosion, day 3, day 4, technical failure is 0, 1, 2 days. So that is usual dictum, though it can happen against it also. Now,
Yeah. Very important point. You should think of a distal obstruction. What could be the cause of a distal obstruction in this patient? Jejunal is definitely.
It's afferent limb syndrome.
Afferent limb. Yes. Any other cause?
Related complications.
Very common culprit is your FJ because you have already left the theatre. Your resident has done the FJ and there is a kink and that can be the cause of this.
One more scenario in this type of cases, specifically in
Sir,
distal
I think mic is not working. Mic. Yeah.
One more common scenario is excessive devascularations in the area of duodenum.
Yes.
Because in order to get extra length of duodenum to get margin, we do excessive mobilization that may lead to escape.
So we can summarize as defective closure, your stapler failure or your technique of closing the stump, a difficult duodenum, a distal obstruction or deranged nutrition. These are 4 things which you need to keep in mind.
Theoretically, neoadjuvant therapy, chemotherapy has also been...
Yes, neoadjuvant therapy also can be a cause. That again works through poor healing. So I want each panelist to give one tip to prevent this scenario because we have another case to discuss. We'll start from Dr. Ajay. Sir, one tip which you would tell your residents
I think
when they do a gastrectomy.
most important thing is the nutrition of the patient. I think if you need one tip.
Next, Nisar.
Technical part. Once we are firing a stapler, which we mostly now do, we don't do hands even. Most of the times I've seen there is a tendency of duodenal splaying and the terminal part, I mean the hepatic part doesn't come in staplers, and then we have a tendency to cut it and just leave it like that. We must particularly take care of that corner technically.
Okay.
The rest of the factors.
If there is any bleeding after staple or two line or triple stapler, there is sometimes spurt. So we should take care of that spurt so not lead to the hematoma, which may lead to the stump fluid in lateral.
Yes. Make sure there is no hematoma. What about cautery on the spurt?
I don't believe in cautery in this.
Yes.
So better to
avoid.
stitch that over.
Yes.
No, I will disagree on that. I think with the bipolar it works equally well.
Bipolar
So I don't think a routine cautery should be
monopolar
used.
cautery is best avoided.
Monopolar should be avoided, bipolar or suture.
Yeah, Dr. Sen,
I
your
think,
tip?
I think one of the most important thing is preventing a devascularization and excessive mobilization.
Excessive mobilization
That's
not
the most
good.
important.
Yes, Dr. Tuhin.
I'll ask not to skeletonize more than 2 centimeters as a stump devascularization. Number 2 is if we are suspecting a difficult closure and we are not happy about the closure, there is always easy to put a tube lateral duodenus to add to it.
How many of you oversaw your duodenal stump in the panel? Just want a show of hands. 2 out of 3. Okay. If it's a tri-staple, would you still oversaw the stump? I don't use tri-staple. Okay. So oversewing the stump, there is no consensus on it, but too many sutures are many times the cause for a stump blowout rather than the cure for it. So many sutures can actually create an ischemic stump. We'll move on to the next case.
No, I'll just point one thing. Regarding the overswing, I think whoever has good results, we have hardly ever seen a stump leak. Whoever has good results with whatever method, be it stripe stapling, with enforcement, without, I think that's good enough. It's an individual surgical choice and the outcomes over the years.
So there is no consensus on whether we should or should not oversew the staple line. But one point we need to keep in mind is if you're oversewing, don't overdo it. Yeah. Second case, the 60-year-old lady, carcinoma esophagus, you have done a thoracoscopic esophagectomy, and again, uneventful surgery according to you. Post-op day 3, again, you get this WhatsApp picture. Dr. Ajay, your resident sends this picture and asks, patient is stable, all well, sir, but the drain looks funny. What to do?
Looks like a Chyle into the drain.
Yes, this is a Chyle leak. So what do you tell him now?
It's a Chyle leak. We have to be aware the patient, if he is not in sepsis, patient is stable. I think I don't need to hurry, except for the fact that I need to now run on his nutrition. I have to advise him subsequently how to manage. There is no immediate treatment for it.
So he's asking, sir, shall I start FJ feeds? He starts past flatus.
Yes, he can start FJ feed, but not. He has to restrict on the fat diet onto it. At least he should not give. He can give medium chain triglycerides, but not the long chain ones.
How many would agree to start enteral feeds as on day 3 or day 4 in a patient who's got Chyle leak in the panel? Dr. Nisar, would you start FJ feeds on day 3 in this patient?
I do usually.
I won't.
On this patient who's got a Chyle leak?
I
So-
do.
Okay. Dr. Utpal?
Yes, there's no harm in doing.
Dr. Sen?
Yeah, I would give. The amounts is also.
Yeah.
Sir, I will give it for a try for aggressive conservative management. I am in favor
Dr.
of
Tuhin
not to
disagrees.
start.
He feels, yes. What would you do?
Not to start. Not to start. I will go to the total parenteral nutrition to start with, and control the infection. Sepsis part we will have to. Electrolyte imbalance I will have to look for.
No, the question is about the enteral feeding.
Regarding the Chyle leak.
About the enteral
Definitely,
feeding.
I will for 48 to 72 hours. I will give it a try for aggressive conservative management in the form of total parenteral nutrition, nothing per mouth, and octreotide. I don't know. There is no consensus about.
So regarding enteral
octreotide.
feeding, 4 out of 5 feel we can go ahead with feeding genostomy feeds. Of course, with some modification, which Dr. Ajay pointed out. Dr. Tuhin feels that we should keep it on aggressive management upfront, stop all enteral feeding, put him on TPN.
TPN, and I'll monitor the output.
I think what Dr. Tuhin is saying is what was practiced for years, for long time. So I think he's not wrong in saying so, because that has been the traditional practice. But now it has been found that even if you stop the feeding, this is not going to stop. If it is not going to stop, it will again restart when you start feeding. So there is no harm in continuing the feeding. There is no benefit.
I think a modified enteral formula is an acceptable option in a patient with Chyle leak. Of course, Dr. Tuhin's plan also is an acceptable thing where you go very aggressive, you keep them completely free of enteral nutrition, start them on TPN. That gives time for the Chyle leak to heal up.
Second, it will help to decide on the future course of action also. I will closely monitor the output. If it is more than 10 ml per kg per 20 in 24 hours, definitely after 72 hours, I won't continue the conservative management. I will go shift to another.
Yeah, we'll come to that.
Yeah.
So post-op day 8, the patient is still having ICD output of 400 ml of Chyle, but patient is stable and he is getting your enteral feeds. Would you change your plan of action or would you consider the same thing, Dr. Sen?
See, post-op day 8, 400 ml, the outputs are probably coming down. Patient is stable. I would still like to wait. I'll go for the volume shifts would be there. So give the fluid electrolyte balance.
Would somebody want to
Adequate
consider
drainage.
stopping enteral nutrition now, put him on TPN because it's 8 days now, patient's bill is going up, the ICD output is still the same.
But you said it's coming down, na?
It's 400 ml.
It's same 400 ml.
It's same. It's stuck there.
Yeah,
See,
some
I won't
people
give you
can,
scenarios
some
where
people
it's very
can
easy to decide.
start
I
it.
won't say it's 1 liter when the answer is very clear. This is a real life scenario. You might have a patient who's well and unwell, and that is where is the experience we need. Dr. Ajay?
No, I'll continue with the feed. I don't think it's still in control. Everything is fine. And only thing that parenteral nutrition can add is that he is losing on calories. So it can help us build up calories so that because we know that we have to still fight long for him.
Okay. Others also agree?
Yes.
Okay. Will anyone use somatostatin at this stage? Will you advise them to start on injection octreotide? You think it helps?
Recently, there are 3 studies which have shown that somatostatin, octreotide, and there is one more drug which they have used, and they have shown some benefit. But none of the trials have shown that it will stop the leak. They have shown that it will drastically decrease the amount of.
So for 400 ml, would you think somatostatin, quite expensive injection, you think your patient can be given that? In this case, will anyone want somatostatin to hasten the closure of the
If you want to
fistula?
start octreotide, then it should be in day 1 only, not in day 4 or day 5. And second, octreotide can help when output is very much high, around 1000 or not in 400.
It is useful for a very high
no
output.
evidence to support any role of octreotide in this case.
Okay, well, what is the main, so now we are prepared for a long drawn battle. He's stuck at 400 ml, he is well, but this chyle leak is not stopping. So what are the other, now you start worrying about the consequence of chyle leak. So Dr. Sen, what do you think these patients who have chyle leak you should watch out for?
See, the first
different from a regular post-operative?
See, basically what happens is with chyle leak, they'll use a lot of the long chain triglycerides are the problem. So they leak out fat, they leak out a lot of fluid volumes, electrolytes, leukocytes, chances of immunosuppression. There's definitely chances of sepsis, poor wound healing. And we'll also have to think there is an underlying esophagus anastomosis. So due to malnutrition or this infection, though that anastomosis can also have a leak. So the most important thing is to look at the content and
how will this
trend.
translate into your post-operative advice to your resident?
See,
these points, what will you change in the orders?
See, the change is basically
in
the
terms of
fluid
investigations, in terms of
electrolyte
medicines.
balance has to be done. So we'll have to look into the electrolytes on at least 24 or 40 days basis and correct that. If you're continuing with the enteral feed, then we'll have to continue with the proper low fat mixed and triglycerides, or maybe even without fat, and give high protein diets. So that has to be there to look for sepsis. We'll send the drain fluids for culture if there is any culture change in the color, change in the clinical parameters. Very vigilant about the clinical status of the patient. So all these things needs to be taken care of before deciding on the next course.
Okay. So it can be nutritional, immune, fluid and electrolyte. All have been covered. So quick, time's up. So quick answer. Which patient would you take up for surgery? Dr. Nisar?
I mean, patients whom we have given a conservative trial or who have a very
how long will you, if he's stuck at 400 ml, what will be the day when you come to the ward and say, take him to OT, I want to operate?
If it is 400 milliliters, patient has a well-controlled fistula, patient is maintaining somehow with enteral nutrition and parenteral nutrition, I will not intervene. I will prefer then a delayed intervention.
Will you discharge him?
Exactly not. But so regarding surgical,
so how long
specific
will you
question
wait?
of surgical
it's day 20
intervention.
now.
Regarding this surgical intervention, patients...
Yeah, it's day 20, your patient is status quo. Drain is status quo, he is well, you're managing him with your enteral nutrition, your fluids, everything is going on, but he is neither moving front or back. So what is the time limit at which you will say he needs surgery?
I mean, post 4 weeks, I'll have to then take a call about his surgery.
You'll wait for 4 weeks.
Yes.
The rest of the panel agrees that we can wait for 4 weeks with the chyle leak?
Yes, it's one depending upon the nutritional condition. If it is doing good, because each liter of chyle contains 20 to 60 grams of protein, and it is almost impossible to replenish that amount of protein by giving low fat protein diet. Specifically MCT, which is very costly. It looks very easy, but it is very difficult to manage, not palatable. So I will like to wait for 1, 2, 3 weeks. Maximum 3 weeks. If it is still going and the patient is having nutritional depletion, I will do CBC counts. If lymphocyte count is low, there are chances of secondary infection.
Okay,
so I will
3
go
weeks
for
is your time unless
up to
something
3 weeks.
else
Up to 3
happens.
weeks.
Which is the patient with chyle leak who you will directly decide to take for surgery?
High
Forget about
output.
this patient. What is
High
your
output.
high output definition?
It is, I think, by definition more than 1000 ml.
And for how long will you wait with 1000 ml? On day 1 you will take up, or?
Early, it is not, if you see, it is the worst time to go in beyond 4 days, and up to 80 days up to 40 days is a bad time. But if you can go in before 4 days, then the indication is very clear that you are having a high volume. If you are having a low volume, then you may have to wait so that it stops, maybe by day 6, day 7. If it is not healing, then what Dr. Uttam has said, Dr. Utpal has said is very correct, that it is the defined criteria is 3 weeks. So you have to wait for 3 weeks. If it is, everything is under control. If it is not under control, go as early as possible.
Okay.
So basically, if it's a high volume more than 1 liter, so maybe 2-3 days you put it on TPN and see. It's not coming down, you have to go.
Okay. So general accepted thing is for a week you wait, and if it's high output after a week, then you decide about surgery. Okay. Quickly, I want one answer from one tip from each of the panelists. any tip for the surgeon who is doing an esophagectomy to prevent chyle leak?
So always check for chyle leak in the anatomical area of
No, this is at the index surgery. Now you're introspecting the original surgery.
Okay, sir.
Any tip for a surgeon to prevent thoracic duct injury during esophagectomy?
So one tip is you will have to be very careful about especially in the region of the midline and near the aorta, and always before coming out check for any leak in the region anatomical area of thoracic duct.
Okay. Dr. Nisar, your tip for the surgeon?
I would prefer, especially in the initial part of care, I would prefer routine ligation.
So you do routine ligation?
Clipping rather.
Dr. Ajay?
We have not had a problem till now, and we have not ligated till now. But the day when it comes, I know it will be a problem. So only thing is keep yourself away from thoracic duct. And second thing what you can do is come and pray outside that it doesn't happen.
Anyone gives uses any technique like ICG or preoperative fatty food to identify thoracic duct?
ICG is one option. We have not done fatty thing. But ICG is now coming big way.
I think fatty food is not the...
It's for leak. It's for leak usually.
No. Fatty food is to test the leak content triglyceride, but to test it intraoperatively, it is milk.
Yeah.
It is milk. Milk has to be given, and there is a defined criteria that you have to give it at least 4 to 6 hours prior to starting the surgery. But we have never used it. It's all theory that we have read.
Okay. So I think time is up. I thank all the panelists for a very enthusiastic and educative session. Thank you.